All right, we are going live from UNE COM. So we're really excited to be joining AACOM's chat room for a OMT explanation and demonstration by some of our clinical faculty, as you can see on the screen. I'm the voice behind the camera and will also be operating the camera and monitoring the chat room. So if anyone has any questions for our faculty and related to OMT, things that we discussed throughout the session, you're more than welcome to pop them in the main chat. And I kind of want to just do a quick sound check. So if a few of you wouldn't mind just messaging the main room just to make sure our sound is working, you can see us and hear us, I'd appreciate that. Awesome. Thank you all. So no one else needs to send a sound check, but we appreciate that. So just to introduce myself, the voice behind the camera, my name is Elise Murphy. I work for the University of New England College of Osteopathic Medicine. I specifically work in the Office of Recruitment Student Alumni Services, and I am a recruiter for the college and more than happy to talk to anyone about the program. And I will share my personal email in the main chat for anyone who wants to connect with me. But this session is really about talking about the osteopathic approach, the philosophy, and really kind of diving deep into OMT, what it is, how do you use your hands to, how do you learn these skills to help your future patients. And we do have two of our clinical faculty, alumni, which is even more exciting, on the camera, and they're going to introduce themselves and kind of go into the session. So what I will say is we will take some breaks to answer questions. So in between some of the techniques that we will be demonstrating today, you're welcome to submit a question, and if you do need any clarification or follow-up, we will use that time to kind of answer those. So I'll turn it over to the two people you can see on the screen. Would you mind introducing yourselves and sharing a little bit more about who you are, and we'll go from there.
Certainly. Well, I'll start out. I'm Chris Frothingham. Good afternoon to you all, or good maybe late morning if you're out on the West Coast. I am a 2001 graduate of UNE, University of New England, College of Osteopathic Medicine. I also did my family medicine and osteopathic manipulative medicine combined residency here at UNE, graduating in 2005. I spent 5 years practicing out in Oregon. So again, props to all of you out in the Northwest. And then returned back to Maine to join the faculty. And I've been back on faculty here for 10 years. I'm currently an associate clinical professor and the course director for the Osteopathic Clinical Skills 1 course that happens in first year. My clinical practice at this point is 1 day a week in the hospital at Maine Medical Center, and I work on the OMM inpatient service. So we are a consult service, and we just circulate around the hospital and provide osteopathic treatment to patients as needed.
My name is Kiran Mangalam. I am also a graduate of the University of New England College of Osteopathic Medicine 2004. And after I left UNE COM, I went and did my family medicine residency at Maine Dartmouth Family Medicine, and then practiced primary care for a few years on the West Coast, and then came back to Maine and ultimately did another training in osteopathic manipulation. And so I'm board certified now in both family medicine and osteopathic manipulative medicine. I've come back onto faculty here at the University of New England College of Osteopathic Medicine after being on faculty at a residency program for a number of years. So I'm very excited to be back here and teaching. My clinical practice involves mostly working with pregnant women and newborns and that immediate postpartum period, treating those patients with osteopathic manipulation, and really enjoying teaching at this level again. What I thought I would also spend a little time talking to you about is a little bit of the background and history of osteopathic medicine, and we'll move into a little bit of a explanation of some of the techniques and show you some of the techniques that they utilize. One of the things that's really amazing about osteopathic medicine, when you think about it, is that osteopathic medicine is a homegrown U.S. Form of healthcare. When you think of medicine, typically what we think about in terms of allopathic medicine, that really came over from Europe. Osteopathy was created and flourished here in the United States. It's now moved throughout the whole world, but in the ashes of the Civil War, that's when A.T. Still, the founder of osteopathy, really solidified his thinking about osteopathic medicine and how to apply that to help mankind. When you think about osteopathic medicine and what makes it distinct from what people think of in terms of traditional Western medicine, is a really holistic focus with, first and foremost, this understanding that the human being is a triune entity, meaning it has spirit, mind, and body all interrelated. And because of that, all of those aspects of the human being need to be addressed when you are dealing with any sort of pathology or form of suffering in a human. The other thing to pay attention to is that within each one of us we have self-regulatory and self-healing mechanisms. These abilities are innate in all of us, and as long as everything is functioning well, the body can self-regulate and self-heal. When things are not quite functioning properly, then there's more assistance that's necessary. The third thing that I think is very important and unique to osteopathic medicine is that structure and function are intimately related. And I'm sure you all have spent a lot of time in science classes already, and you know that the structure of a molecule impacts how it's able to function. The same thing is true of all of the cells of our body and the gross structures in our body as well. So if we take these three concepts and we look at them and then base rational treatment on those three tenets, we can create a holistic form of healthcare for people.
So, as far as how we think about applying that to the care of our patients in a unique way, I can give you an example. I had cousins born. They were twins, and one of them was extremely colicky. Basically, screamed when she was awake, fed very poorly, spat up all the time, was extremely constipated, and all that makes for an extremely unhappy baby and therefore a reasonably unhappy household. And at about a month of age, people were invited to come and meet the new additions to the family. And so I took about 20 or 30 minutes to just sit down with her in my lap, and she fell asleep, which was great. And I treated her using osteopathic manipulative treatment. And I'll go into some examples of what types of things I could have done. But treated her, and then my family and I headed out. And 3 hours later, I got a call from the dad saying, "I don't know what you did," which is sort of an alarming thing to hear as a clinician. But it was followed by, "She has had 3 huge bowel movements and has fed like a champion and is sleeping longer than she slept yet." And she ended up not needing treatment again after that. Sometimes there is more follow-up needed, but it's an example of if we think osteopathically about what's going on with our patient and think about their structure and the impact that that's having on the function of their organ systems, what I was able to help her body accomplish is regulate its own bowel function really through the whole gastrointestinal tract by virtue of affecting the nervous input to it, any structural impact directly on the gut, as well as the circulation into and out of the gut. And so as much as it would be nice to be able to say, I fixed the problem, I simply addressed some of the areas that weren't really functioning correctly so that the rest of our system could take over and function normally. And so that's the kind of thing that we're able to do with the training we get at osteopathic schools, is apply that to everything else we would normally do for a patient. And so when we talk about OMT, or osteopathic manipulative treatment, that encompasses a wide range of different sorts of approaches. And most likely some of you have had maybe a lot of osteopathic treatment. Some of you have had none. Some of you may have some familiarity with it secondarily. Perhaps you've seen chiropractors, or you've seen other physical therapists, massage therapists who do similar things or some of the same things that we're taught. And so you have an idea of what this entails. I think a lot of people don't have a very clear idea of what this is. So there are a number of different techniques, approaches that can be used. And what Kiran and I are going to demonstrate today are three of the techniques, the ones most commonly taught in first year, at least here at UNE. Those would be strain, counterstrain, muscle energy, and high velocity, low amplitude. And probably high velocity, low amplitude is the first thing people think about when they hear manipulation. So that would be the thrust techniques, the cracking and popping sorts of things. And so that's one of the things that gets introduced in the first year here, at least. Muscle energy is an approach that particularly some of you who are athletes may have experienced. It's a little bit like an activated stretching, I guess you could describe it. And so you take an area that's not moving, bring it as far as it can go, and then have the patient engage musculature to try to get things to activate and then relax, and then see if you've improved that range of motion. And we'll demonstrate an example of that. And then strain counterstrain is actually quite the opposite. If there is something that is tender or tight, you put somebody in a position to shorten it up as much as you can so that it no longer feels tight or no longer feels tender, and hold that position for about 90 seconds, and then slowly bring the person back to a normal position. And typically the tissue that was tight has now been able to relax. So those are three of the fundamental approaches that get taught, along with soft tissue, which I'm sure many of you have had in one form or another in first year. And I would say that at different colleges of osteopathic medicine, the order in which things are taught is a little bit variable, and what techniques get taught in first year versus second year is a little bit variable. But the techniques, by and large, that get taught are the three that I just mentioned: counterstrain, muscle energy, and high velocity, low amplitude, soft tissue, myofascial release, balanced ligamentous tension, facilitated positional release, which falls under a functional approach. Ligamentous articular strain is another one. Some of you may have heard of craniosacral or cranial osteopathy, or osteopathy in the cranial field, or sometimes just cranial. That's another approach that is used. So there are a number of different approaches that do get taught, and for all of these, the concepts are introduced and examples are taught, and then it's up to us as we progress through our residency training and our careers in practice to continue to add to our understanding of how we can apply those principles in areas that we weren't shown exactly how to treat. So At all colleges of osteopathic medicine, we try to instill in you the foundation, the fundamental knowledge of anatomy and its function and the basics of these techniques so that you can then go and apply it. So I was not taught as a student what to do for a colicky baby, but through the course of my training, I learned how to think about what's going on with a colicky baby and how to assess the tissues and a number of different ways to treat those things so that I could get a good outcome for my cute little cousin. That's some of the background of what OMT is. And that's certainly something you'll hear a lot as you continue to pursue your application and training. What we'd like to do now is demonstrate some techniques. And I think Dr. Mangalam is going to be the patient first, and I will demonstrate strain, counterstrain. And given the nature of this, as I described, it takes 90 seconds in a position. And so I'll have time to describe what's going on. I'm just going to get a little hand sanitizer here before we start. And it's probably worth just speaking briefly to this point as well. Many health professions, and certainly all medical schools, allopathic or osteopathic, are currently faced with an incredible challenge of teaching clinical skills to students when we're really not supposed to be within 6 feet of each other, much less touching one another. And so all schools, you have to learn how to listen to somebody's heart and how to palpate, feel their abdomen, and assess their pulses and take a blood pressure and look in their eyes and their mouth. And then in osteopathic colleges, there's also the added manual assessment and treatment approaches that need to be taught. And so all the comms and all med schools are undergoing processes of putting in place measures to keep everybody safe and healthy. And so beyond being aware of and screening for active symptoms of coronavirus infection, when people are well and can be on campus in small groups, at least at UNE, we will be working with students in groups of 8 in the first year and groups of 10 in the second year. And so if Dr. Mangalam and I were students and were partners, we would fill the role of patient and physician for one another to learn and practice. And so the protocol as it stands right now is that we would be wearing scrubs. And as the patient, you noticed he took his white coat off. So this, right now, the white coat is serving in place of a washable gown. But it's another layer of personal protective equipment. So I would continue to wear this to keep both of us safe. We're both wearing masks. I've sanitized my hands. And for the sake of this demonstration, because we don't have face shields available at the moment, we're going to work from waist down. But as we are working up closer to the head, we will add additional precautions. And this sort of thing is happening throughout schools all over the country. So safety is certainly a primary concern. So moving into this technique, what we wanted to demonstrate is counterstrain as one of the techniques. And the psoas muscle is a very powerful hip flexor, meaning it brings your leg up like this. And it's a common problem in athletes. It's a common problem in people who sit on Zoom meetings for hours and hours a day now that they can't get up and walk around their workplace. Because it gets short. When you're sitting, it's shortened up in this position, and then we go stand up to do something, and it gets strained. And so strain counterstrain is a really nice way to treat that. The way we would assess that, I'm going to assess your pelvis and your psoas. Is that okay? All right. So we want to get consent. I'm going to find the prominent landmark on the front of the pelvis on each side, on his pelvic bone. and then move just inside and tender on either side.
Yes, that's
Right. So he's indicating that the right side, when I push in, and so from this landmark here, I'm just moving toward the middle and pushing in deep. And on his right side, that's tender. But interestingly, to me, it feels tighter, feels like there's more resistance in the tissue on his left side. So as a clinician, I want to concern myself with both sides, actually. So the principle of counterstrain is that if we've identified a problem, dysfunction, somatic dysfunction in the psoas muscles, which we know flex the hips up, what I want to do is flex his hips up, but I don't want him to help. So the muscle needs to be relaxed and I want it shortened. So the way I'm going to do that is to bring his legs up. So I want you to relax. I'm going to put one leg up on the table and then bring his other leg up. So now I've got him in a position that shortens that muscle. And if I come back here, the tone feels more even on the left. How's the tenderness on the right? Pretty good?
Good.
Okay. So, and there are specific guidelines to how we do this. We want to have a 70% reduction in the tenderness or potentially in the tone that I was feeling. And I'm going to actually try to spend 90 seconds describing all this so that we can actually get an outcome. But the idea here is that we spend 90 seconds with the muscle relaxed and shortened. During that time, it is no longer triggered and sending alarms to the central nervous system. And so the central nervous system then can let go of the tone in that muscle. And when I slowly bring his legs back down and that muscle lengthens back out, its tone should be more normal. And what that will feel like to me is less tone on his left side. The tissue should be looser. And when I poke on the right side, it shouldn't be uncomfortable for him. So, and this is one of the nice things about this approach, and really about osteopathy in general, if you're using OMT in your practice. As you can see, this, if I'm not talking at a camera, I can talk to my patient. And so you have time to really develop a great deal more rapport with your patient than if you're having to rush in and out, write a prescription, and dash on to the next patient. And I've found that I get to know my patients personally much better, and I think they get to know me in turn and trust me more, and I think I get much better information out of them. And it's really fun to spend time treating somebody and to see the smile on their face when they get up off the table and their shoulder feels better or their back feels better or whatever the problem is has improved noticeably. It's wonderful. So I think that has been, if I've seen the second hand correctly, I think that's been about 90 seconds. So I want you to totally relax, don't help. And the goal here is to let his legs back down slowly, gradually, and passively, so he's not helping, no helping. All right. Now, when we teach this, we instruct students not to take their finger, their monitoring finger, off the tender point. I had two that I was dealing with, so that was a little tough. So how are we doing on the right?
Good.
Okay, he says that feels better. And if I compare, I would say the left is still slightly tighter than the right, but less so than before. So what that then says to me is there's a next step. That left side didn't resolve entirely, but it improved. There's probably still something else that I need to go address. So that would be an example of counterstrain, and we can do that almost anywhere. If you find something that's tender, that isn't a cut or a bruise or something like that, you can usually find a way to put somebody in a position that will ease that. It's also nice because it's something that you can very easily teach your patients to do. So if this was a chronic problem for Dr. Mangalam, I might say, well, if this starts bothering you again and you can poke in here and it's tender, I want you to lie on your back and put your feet up on a chair with your ankles crossed and just let your knees flop out and see if you can get to a position where this feels at least 70% better, and then relax for 90 seconds. And I can give them instructions about that, so patients can often keep their own symptoms at bay using these techniques. So, do we want questions now, or do we want to proceed to the next thing? All right, we're going to roll along. So I think now we're going to change roles. So I'm just going to get out of my white coat.
As we switch over to the next technique, I just want to remind anyone on the call, you're welcome to submit group questions to the chat room in between each of the techniques. We're happy to answer any questions if you need clarification or want to hear more. That is something that you can certainly use. So we'll get ready for our next technique.
So Dr. Frothingham walked us through the treatment of using counter strain. So what I thought I would do is now do another evaluation of Chris and see how we might be able to utilize the techniques of muscle energy and HVLA for the issues that might come up for our patient. So what I'm going to do is similarly, I'm going to evaluate his pelvis, his hip bones, and when I evaluate it, it's as if his left half of his pelvis is, in comparison to the right side, is rotated posteriorly. So it's kind of moving down towards the back of the table. So that's one thing that I've noticed. I have to kind of have my brain start going through the process of what could potentially be causing that to happen. So one of the things that could be happening is if there are muscles from the back side of his body pulling on his hip bone, that itself could be making it rotate a little bit. There could be a restriction within the joint itself that's causing that to happen. So this is part of that structure and function relationship that we're looking at. So one big muscle that definitely can affect that is the hamstring muscle. So that's one thing that I wanted to check to see how that might be affecting him. So if we flex the hip and then begin to extend the knee, I can get a sense of how much that is being restricted by the tightness of the hamstring muscle. So thankfully he's got two. So you can check the other side and see if there is a discrepancy. Actually, that's not as bad as I thought it's going to be. It's always good to double check. And I think we will try to do this side. So in this instance, if we think about this left side being slightly more restricted than the right side, what we can do is we can put this hamstring into a bit of stretch and then have the patient actually try to contract that muscle, then to allow the patient to rest, and then try to stretch the muscle even further. So this is a way to elongate that muscle to try to improve the muscle length, but also to see if there might be any change that happens with the joint itself, with the position of the bone. So if we start by putting the muscle into a maximal stretch and then applying a little bit of resistance, and then have the patient try to bring his heel down towards his buttocks. Can engage that muscle, and I'm not allowing his heel to move down towards his buttocks, and then have him relax. And then as that muscle relaxes, I can then attempt to stretch the muscle a little bit further. And then when I find restriction, I can hold it in that spot and then have the patient bring his heel down towards his buttocks again. And then relax. And as the muscle is relaxing and resetting itself, we can extend the muscle a little bit further. So in this period, after the muscle has engaged, contracted, that post-isometric relaxation, that's the point where I can stretch the muscle further. And then we'll try one more time. Good, and then relax. And then as that muscle is relaxing, stretch a little bit further. Great. And then, as with the counter strain, I'm going to ask Chris not to do anything, and I'm going to slowly bring him back down to neutral. Let all the muscle relax. And then we'll recheck the length of the hamstring. And that's pretty good increase in the length. Let's just check this right side that we didn't do anything with. And that was similar to where the left was. So we've definitely gotten some improvement. So that allowed an elongation of the hamstring. The next question we have is, did that affect the rotation of the hip bone itself? Because as you'll remember, when I was pushing upon the front of his hip bone, it felt like there was restriction. And there's still a bit of restriction. So this isn't an opportunity, since we've treated some of the muscles that are holding that bone in place. Now we can actually directly go towards the joint and see if we can use high velocity, low amplitude, or HVLA, a treatment technique, to, in a sense, actually force the joint to move a little bit to get it into a proper position. So what I'm going to do here is what's called a traction tug. So I'm going to lift up the leg, and in this particular case, I'm going to try to get the angle between the table and the leg up to about 30 degrees. And getting at a point where I'm not pulling in through the acetabular joint, which is the joint going from the femur into the hip bone, but really focusing my vector such that I'm pulling on the hip bone where that attaches to the sacrum, so the sacroiliac joint. And then once I've pulled the joint to the point where I've taken up all the slack, then a slight pull, creating some traction and tugging the sacroiliac joint into position. Good. And so that restriction that was there at the innominate, the hip bone, where the hip bone is meeting with the sacroiliac joint, that's now improved. So we would correlate this with now the symptoms that the patient had, because most likely when patients come in with issues such as this, they'll have pain in their sacroiliac region, perhaps they'll have inguinal pain or low back pain. I've actually had male patients that have had testicular pain that could be caused from entrapment of nerves in this area. So yeah, are there any questions maybe?
We do actually have a few questions, so if Dr. Frothingham, if you want to sit up, or you can keep lying down if you want to. Get comfortable.
It's probably too comfortable.
I'm going to sit back down at the computer and see kind of what we have here. So just so people are aware, we are recording this session, and I will send it out, a link to the video sometime next week to the full registration. So if you do have to come and go, you're totally welcome to check this out later on. But I do have a few questions that we've gotten submitted, so thank you. So Taylor asked, are the labs to learn/practice this techniques semester long? So would you mind kind of explaining to Taylor and to everyone else on the call, when do students learn their OMT techniques throughout their first and second year, and for how long, how many hours?
I can't speak to the specifics for all different colleges of osteopathic medicine, and so there is some variation from school to school. I can say at UNE COM, we have typically had the students have 4. It's a little hard to tell because our curriculum is fairly integrated. There are 4 hours of lab time that are primarily focused on learning to do the assessments that we demonstrated and then the treatments that would follow if you find dysfunction. There are an additional 4 hours that are spent primarily focused on all the other clinical skills, the other physical exams and history taking and that sort of thing. But part of the structural assessment skills and even some of the treatment skills are practiced in that time. We also, this year obviously is a little bit different because of COVID, but in the past we've had 6 hours a week in the anatomy lab or the donor lab. And in the donor lab there are clinicians who circulate around through, and so there is often a clinical aspect thrown in while the students are dissecting in the anatomy lab. And so there may be not practicing the skills, but thinking about them and thinking about them in the context of the dissected anatomy that you would be treating right at the time. This year we won't have as many hours in the donor lab doing dissection, but we will still have 4 hours of time in the primarily OMM or the manual skills focus and 4 hours in the primarily clinical skills focus.
And those will be, you'll have time in both your first and your second year to continue to learn these skills. It's not something that just learned at the beginning of your medical education. It's something that's continued to practice, and as Dr. Frothingham had mentioned in the beginning of as he was introducing himself, this is a whole career of learned skills. So some of the things that you may do later on in life may not be learned specifically in medical school. Right. So I appreciate that question, Taylor. Melanie asked, does UNE include OMM in residency? I think maybe the question is in rotations, and we do require students to do an OMM rotation in their 4th year. So I hope that kind of answers your question, Melanie, but we do have students who will do an NMM residency, correct?
Correct.
So David,
I could just to interject. My answer to Taylor's question maybe wasn't entirely complete. So that answer applies to first and second year. During 3rd and 4th year, 3rd year in particular, while our students are on core clinical rotations, so they're all out at sites that we have specific affiliations with, and they're in groups. We, as faculty, and some on-campus faculty and sometimes faculty from other sites, every quarter, twice a year, at least historically, have gone to groups of sites, and all the students rotating and residents in what were previously DO programs, residency programs, would all spend a whole day at the site, and we get a number of different didactic lectures and learning, and some of us would go and teach more hands-on skills, and there we would teach a little bit more advanced things, or things that maybe weren't in the textbook, so to speak, that we use in the first and second year. But Elise was correct that there is an OMM rotation requirement, and you can now with residency, with the single accreditation system, any residency may seek osteopathic recognition, and if that's the case, and if these are skills you're interested in fostering through your training, if you seek out one of those residencies, they will have a curriculum, and there will be requirements for you, and MD and DO graduates alike can participate in that. And then there is specifically an OMM or NMM, neuromusculoskeletal medicine residency. I did mine combined with family medicine. Dr. Mangalam did family medicine first, and then the NMM additionally afterward. So there have been two ways to do that before. So residency, there are opportunities in residency, but it's not guaranteed.
Okay, well, I appreciate that further explanation going into third and fourth year and even into residency, how you continue to learn these skills. David and Siyun, sorry if I pronounced that wrong, kind of asked similar questions. In the clinical setting, how much time is there to practice these techniques, especially in the outpatient setting when appointments are often limited to 20 to 30 minutes? And Siyun's question was, how do you secure time to perform these techniques? Would you have to work in a private clinic?
No, you don't have to work in a private clinic. It is the big question that we all face is how do we incorporate the osteopathic manipulative treatment in the context of all the other things that we have to do in medicine. It's a challenge. There's no way of getting around that. It's a challenge, and we are always trying to find ways to give the patients exactly what they need. So it does take time, and not just with manipulation. In all of medicine, where we're always we never have enough time. So it is a challenge, but it is something that we have worked hard at doing, and we can help show you how.
Well, I think that answers that question. We certainly wish we could have more time in the day, don't we? Or maybe we don't. So Stephen asked a question in relation to the technique that you were doing, Dr. Frothingham. So he said at the end of the technique just demonstrated, you did mention teaching the patient to do this at home. If so, is there visible differences between the patients who are keeping to the prescribed regimen and patients that do not? And how do you find the time to ensure the patient is correctly practicing their prescribed exercises? Great question, Stephen.
Yeah, that's a very good question. So I'm hearing a couple of questions in that. So the first part that I heard sounded to me basically like compliance with the treatment plan. And so I would say I do notice a difference when a patient has been doing the self-treatment or the stretch or the exercise that I've recommended, because when they come back, they maybe haven't slid backward quite as much. I would say the same, however, of somebody who comes in and you check their blood pressure and they have been taking their medication or they haven't been taking their medication. I think you can draw the parallels in almost any aspect of the care that we recommend. One of the really nice things I think about OMT is that now there are things that you can do using OMT to help improve somebody's blood pressure, since I kind of stepped into that example. You can do things that will affect the heart function. You can do things that will affect kidney function, that will affect the tone to the blood vessels. So things that you know from your training play a role in contributing to high blood pressure also can play a role. That's an avenue to contribute to lowering the blood pressure. So there are OMT approaches that you can use, just like getting a colicky baby to finally poop and feed and sleep. You can get somebody's cardiovascular system to regulate better. But it's still usually dependent on lifestyle changes and medication being taken as recommended. But the nice thing about OMT is that, particularly if you have somebody who has, the classic example is back pain. If somebody comes in with back pain and you prescribe medication to control the back pain, that may be helpful, but they don't walk out feeling any different, and it's totally dependent on them to take the medication. If you give them exercises to do, they don't walk out feeling any better, and they don't until they do the exercises. If you do OMT, they walk out feeling better most of the time. And so you can make a change, and even if they're not compliant with the rest of it, you're pushing them a little bit in the right direction every time they come in. So you have that little bit of control over what happens. Patient compliance is very challenging, and a lot of it has to do with how well you can motivate your patient. And circling back to what I was talking about when I was demonstrating the treatment, we just demonstrated a couple quick things. If you're in a practice and you use these skills a lot, you spend a lot of time rolling around the table on a stool with your hands on your patient, talking with them, and you figure out the things that motivate them. So, I might know to say to this particular patient, look, if you really want to be able to get out behind that ski boat and slalom ski and take jumps, I think this will really help, and that might do it. And I might not know that about them if I didn't spend that extra time doing the treatment. So I apologize for wandering a little bit from the topic. So if people are doing the exercises, yes, I definitely do see a difference. And sadly, I think I wandered far enough that I have forgotten the second part of the second question I was hearing in that.
Let me find the question again, because then I was scrolling looking at other questions. So Stephen's question is there a visible difference? And then how do you find the time to ensure the patient is correctly practicing these prescribed exercises? So I think you kind of did answer that question. One question that I certainly want to take some time, and I think we do only have 7 more minutes of the session. I know you were going to, what was the other technique that you were going to perform? We don't need to do it because I think I'd rather have the time spent on answering some of these questions.
That's fine.
No, that's fine. I don't think there was another one we were planning to do.
Oh, very good.
That's fine.
So somebody asked, how can OMT be used in specialty care? Or what specialties can you utilize OMT in? I know from past demos with some of our students, they've mentioned, if you have someone coming post-surgery, helping them relieve maybe gas or constipation they're feeling, and providing some techniques to help them maybe get out of the hospital quicker. So what are some other specialty fields that you can apply OMT to?
I think my answer would be, I don't think I can think of a specialty field where you can't utilize some aspect of OMT.
I like that answer.
So if you think about those tenets of osteopathy that we talked about in the beginning of this session, if we're looking at trying to apply osteopathic techniques and osteopathic philosophy to looking at the person as a whole, looking at their structure and function, and looking at a way to help that body self-regulate and self-heal, we can apply various different types of modalities to that philosophy. So I've seen psychiatrists utilize OMT, I've seen oncologists utilize OMT, I've seen anesthesiologists, definitely primary care, obstetrics, internal medicine, All of those fields are very well suited to OMT, but really any specialty.
Yeah, I would agree. I think there are few, if any, specialties who see patients who cannot benefit from this. And the reality is not all specialists, maintain their skills in it, or if they're allopathic, they maybe weren't taught them at all, but or just the reality of the structure of practice management and revenue generation is unfortunately what it sometimes comes down to. It's not always feasible for a surgeon, for example, to spend her time doing OMT that she can't bill as much for as she can being in the OR. But if she knows and is knowledgeable about this, she knows to consult somebody, such as the service I'm on at the hospital, we come in and we do the manipulation. And so a patient can benefit from that prior to surgery, so everything, circulation is good, any antibiotics given beforehand are well delivered by the circulatory system, their nervous system is functioning well to regulate all their systems, and then after surgery, they've been in an odd position, they've been cut open somewhere perhaps. One of the big things that we see is cardiothoracic surgery patients. They've just had their sternum cut open and pulled apart, and not surprisingly, they have pain between their shoulder blades the next day. And we can come in and get ribs moving again and get their spine moving again and get everything sorted out that helps regulate their heart and the healing of that tissue all through their chest. And it gives them a great deal of relief. So it's wonderful if you can do it as the specialist, but at the very least, if you know enough about it to recommend it and consult for it, that's a key part.
So Hannah asked, do you think that by using OMT we can help prevent patients from developing reliance for addictive pain medication?
Mm-hmm.
That's one of the things that here in the state of Maine, we had, as with other states and throughout the country, we definitely had an issue with opioid use disorder. And that's something we have a very large percentage of our physicians here in the state that do practice OMT, and that's been a huge benefit to our patients and helping them get off high quantities of opioids. So I think it's a very wonderful pain management adjunct, but that's not all that you can do with OMT. But yes, a very astute observation.
Mm-hmm.
Well, thank you for that question, Hannah. And I think we're going to end up with one more question from Laura. And it kind of was going off to what we asked about Taylor, about these exercises that patients can use at home. She said, would some other physical fitness regimes, such as yoga or stretching, result in similar benefits as does OMT? She's a registered yoga teacher, and there seems to be many similarities. So any thoughts kind of on Laura's observation there?
So before medical school, I also was a registered yoga teacher, and yes, definitely, that is a possibility. And what we're looking at is then when somebody's not able to go through a yoga class or not even able to go see a yoga therapist, when they're beyond that, then that's the point where we can come in and we can offer even further treatment. But yes, if somebody has a great yoga practice, they go to a class regularly or seeing a yoga therapist, that can definitely be helpful. And sometimes we have patients do that as well. This is just a little bit more than that.
Well, great. And it's nice to hear that prior to your pathway to becoming a physician, you were a registered yoga teacher. Do you still practice yoga?
I do on my own. I don't really do much teaching anymore.
That's okay. You know, it's certainly good for the body and for the soul. And I'm going off script because we're going to end with this question. What is your favorite, what makes you so happy about osteopathic medicine? You know, what do you love the most about it? I know, Dr. Frothingham, you said the smiles on your patients' faces, but with masks on, you may not be able to see their smiles.
You can see it in their eyes.
Yeah.
I would say that's one thing. It's most profoundly the look of astonishment on somebody's face that the symptom that they maybe have had for years is gone, and it couldn't possibly be gone because I didn't do that much. The other thing, though, that I love, so that's on the clinical side. The other thing I love is seeing the light bulbs go on for the students. When they get, you're in the lab, you're teaching, they have a palpatory experience that they've never had before, or they fix something that was clearly wrong with their classmate. And if we're being honest, most medical students are pretty healthy and have minimal dysfunction. But if they find something and it corrects and they maybe weren't really expecting it to work, and that's fantastic. I love seeing the light bulbs go on.
So that aha moment,
Yeah.
aha, this actually is something that does work.
Yeah.
What about you, Kiran?
I would have to say the exact same thing. The aha moment for both the patient and for the students, that is so gratifying to me. And that is not something that I've seen in being involved with the practice or the teaching of other forms of medicine. I've not seen that. When specifically with teaching manipulation, that's where I've seen that most.
Well, I appreciate you sharing those sentiments with us, and we will end it here because I know you have a whole schedule of events following this OMT demo, but we're really happy that you stayed with us and watched. I know some of you in the chat were asking if this is recorded. We did record the session, and you'll just have to give me a few days, maybe next week. I will send it out to the full registration list, so if you were able to log in at the end of the hour, you'll be able to see the very beginning. So we're going to go offline, but you are welcome to connect with us later on today. We do have some sessions, so come on and join the UNICOM chat later on. So back to Aaron and everyone at AACOM, thank you so much for this opportunity. We really appreciate it. So everyone have a good one, and we'll see you on the flip side, maybe sometime in Maine, but just Google search Maine beaches and pretend you're here with us.
That's great.
We'll see you later.
Bye.
Bye.